Today it's my pleasure to present manometry as a preoperative tool for sleeve gastrectomy. And sleeve gastrectomy is developing into the most common bariatric surgery in the state of Texas, as presented at the Texas Association of Bariatric Surgery in January 2013. And gastric reflux was shown by Hippins et al. To be the most common long-term complication, occurring in 21% of patients postoperatively. And this is a table showing occurrence of GERD symptoms, esophagitis, and hiatal hernia, both preoperatively and at 12-month follow-up, for 66 patients analyzed by Ty et al. And as you can see, 47% of patients went on to develop GERD symptoms at 12-month follow-up. 67 were found to have esophagitis, and 27 were found to have hiatal hernia. And another study by Carter analyzing 176 patients showed the occurrence of GERD symptoms to increase from 35% preoperatively to about 47% in patients 1 month post-op after having undergone sleeve gastrectomy. And the methods typically used to assess GERD include GERD-validated questionnaire, upper GI series, endoscopy, manometry, and 24-hour pH probe. And there are 15 to 20 different validated GERD questionnaires. The GERD HRQL is the most commonly used, and it can actually be used preoperatively and postoperatively. And this is the HRQL GERD scale questionnaire used in our study, and as you can see, it categorizes the severity of the answers to each GERD question from 0 to 5, with 0 being no symptoms and 5 being symptoms that are incapacitating and leaving the patient unable to perform daily activities. And all the GERD questions are added together to form a total GERD score. And there are currently several procedures used to categorize the amount of reflux and or the presence of hiatal hernia. In this study, we did not do upper GI series, which can be used to demonstrate hiatal hernia, the amount of reflux, and motility, but fails to show LES pressure. And the total cost of the procedure is about $1,875. We also did not use endoscopy, although endoscopy is able to detect the presence of hiatal hernia and show mucosal histology, although it fails to show LES pressure and motility. And the total cost of the procedure is $900. And the key part of this study was the use of manometry. It's able to demonstrate the presence of hiatal hernia, esophageal motility, the amount of reflux, detect decreased basal LES pressure. It doesn't show mucosal histology, but it does have a reduced total cost of $350. And the methods used for this project included reviewing preoperative GERD scores, conducting esophageal manometry with impedance, and reviewing operative findings for all 79 patients. And manometry involves the placement of interluminal pressure sensors within the esophagus to convert pressure signals to electrical signals that can be recorded and displayed. And we can also measure the basal LES pressure, the peristaltic velocity, and the mean wave amplitude and duration during multiple swallows. And the factors we looked at for this project included reduced LES pressure, esophageal motility, the amount of reflux, and the presence of hiatal hernia. And we divided our 79 patients who underwent manometry readings into 3 different groups. Those with a GERD score of 0, or 8% of patients, those with a score from 1 to 5, or 47% of patients, and those with a GERD score of above 5, or 41% of patients. And we also analyzed abnormal esophageal motility, which we defined as a simultaneous esophageal motility with a velocity of over 6.25 centimeters per second. And this was seen in 10% of patients with a GERD score of 0, 8% of patients with a GERD score from 1 to 5, and 6.3% of patients with a GERD score of over 5. And thus, abnormal esophageal motility was fairly consistent across all GERD scores. And decreased basal LES pressure, or pressure below 13 millimeters mercury, was seen in patients with a GERD score of 0. Wasn't seen at all in patients with a GERD score of 0. It was seen in 3% of patients with a GERD score from 1 to 5, and in about 6% of patients with a GERD score of over 5. And reflux, or any percentage of incomplete bolus clearance, as detected through manometry, was also analyzed. And even though some patients had a GERD score of 0, as you can see, these patients were also shown to have some degree of reflux, about 50%. And 24% of patients with a GERD score from 1 to 5, and 44% of patients with a GERD score of over 5 were also shown to have reflux. And manometry was also used to detect the presence of hiatal hernia. Interestingly, 3 hiatal hernias were found in the patient group with a GERD score of 0. And hiatal hernia was also seen in 13.5% of patients with a GERD score from 1 to 5. And this percentage increased to 32% in patients with a GERD score greater than 5. And in this slide, the number and percentage of hiatal hernias is detected through manometry was compared to the number and percentage of hiatal hernias detected during the sleeve gastrectomy operation. And about 14% of patients were found to have hiatal hernia on both manometry and operative findings. And as you can see, many of the hernias detected during operation were small hernias with absence of or minimal sliding component. About 56% of the hernias detected during operation were small hernias with no sliding component. About 24% were moderate hernias with sliding component, and these were the hernias detected through manometry. And for predictive value, the predictive value of this study included using manometry, in this series did not categorize severe pathology and allowed for preparation of simultaneous surgical repair. And it also allowed us to identify the percentage of esophageal dysmotility, which was 7.6%, with no cases of severe pathology, and the degree of reflux, and identifying the presence of hiatal hernia, about 23%, and identifying decreased LES pressure, about 3.8%. And also, the manometry readings allowed the surgeon to progress with sleeve gastrectomy as planned, with repair of hiatal hernias as indicated. And there were no cases in which sleeve gastrectomy was aborted. And post-op GERD symptoms in patients with severe reflux or a GERD score of over 5 and moderate hernia were looked at. And although the nature of the study did not include follow-up data on post-op GERD symptoms, which is planned in the next year, a brief look at the patients with a 6-month follow-up showed that there's been minimal to no post-op symptoms in patients who initially preoperatively presented with GERD scores greater than 5. And in conclusion, manometry offers a cost-effective tool for assessing degree of reflux, size of hiatal hernia, lower esophageal pressure, and dysmotility. And also, standardized GERD scores can be valuable predictive tools, although, interestingly, a score of 0 does not exclude presence of hernia. And that concludes my presentation. Thank you.